take a deep look at how cardiovascular computed tomography can help your patients. Join one of SCCT's hands-on workshops to get real case experience. With virtual access to reading software, learners interact with image-based cases while being guided by experts. SCCT workshops cover a wide range of topics, such as coronary evaluation, plaque features, grafts, valvular heart disease, transcatheter valve planning, structural heart disease, congenital heart disease, masses, pericardial pathology, and other commonly encountered clinical scenarios. All workshops include case credit and CME. Visit scct.org/workshops for more information. That's scct.org/workshops.
Hello, listeners, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. I know that many of you out there have missed our usual corny introductions, but I've decided this time to nix the jokes for this episode intro. I do look forward, however, to having you all cackle the next time around. Huh?
Oh, geez, Praveen, you promised you wouldn't.
No. Do you get it? Cackle, like coronary calcium? Yeah? Come on.
Yes, Praveen. I think we got it.
Okay, anyway, we have quite a special episode for y'all today. But first, let me introduce my wonderful co-hosts, Dr. Suvasini Lakshmanan and Dr. Kashif Sheikh. Welcome, Suvasini and Kashif.
Hi, Praveen, and hello, listeners. Thank you for having us. My name is Suvasini, and I am a cardiology fellow at University of Iowa at Iowa City.
And hello, my name is Kashif, and I'm practicing general cardiology and cardiac imaging at University of Tennessee, Knoxville.
Fantastic. Thank you both for coming on. We are also joined by our esteemed guest, a true titan in the field of cardiac imaging, coronary calcium, and preventive cardiology. Suvasini and Kashif, why don't you go ahead and introduce our guest?
That's right, Praveen. Our esteemed guest is none other than Dr. Matthew Budoff. Dr. Budoff will help guide us through a conversation on the past, present, and future of coronary calcium in this episode.
Exactly, Swasni. As many of our listeners surely know, Dr. Budoff is a prolific cardiac imager who has been really a leading figure in advancing our understanding of coronary pathobiology on cardiac CT. Dr. Budoff has many publications in the field, has won countless awards for his academic endeavors, and is a past president of SCCT and a founding member of SCCT. Dr. Budoff is currently a professor of cardiology at UCLA. Dr. Budoff, welcome on the Donut of Destiny podcast.
Oh, thank you for having me. It's a pleasure to be here.
Wonderful. Thank you so much again, Dr. Budoff, for coming on. Why don't we start by briefly outlining some of the highlights of your journey in the world of cardiac CT and coronary calcium? I know this may be tough, but if we could describe 3 events or moments or scientific endeavors in the field of cardiac CT and coronary calcium that impacted you, it'll help give our audience an idea about your journey.
Well, it really started for me as an intern. I was very interested in cardiology, and I approached my chief of cardiology at the time, Dr. Bruce Brundage, who was new to our institution. And, he offered me to do research with him. And what really impacted me was I went to one of the small meetings, one of the coronary calcium meetings that they had, the kind of a users group meeting, a precursor to the SCCT. And I got very involved in some of the research projects, and it really impacted me in a positive way. I was very impressed with the science, and I started doing my own science, and that's really what started me on this journey.
Thank you, Dr. Budoff. Moving on, many of us are familiar with the MESA registry, the multi-ethnic study of atherosclerosis, and its impact on coronary calcium and its application in risk stratification. Could you talk more to that? And also, what are some other important registries and trials that you think have greatly impacted this field?
Yeah, I think MESA or the multi-ethnic study of atherosclerosis is really a turning point in our understanding of atherosclerosis and coronary artery disease. It was the first NIH cohort that mandated that all participants to be in the study, they had to be asymptomatic, they had to have no known coronary disease, and they had to undergo a coronary calcium scan. So all of the 6,814 participants underwent coronary calcium scanning. And therefore, we have this complete data set that's so extensive. I mean, if you wanted to study the interaction of coronary calcium with kidney disease, there's multiple kidney metrics. We have MRI, carotid ultrasound, we have ankle brachial index, flow mediated dilation for brachial artery, endothelial function testing. There's just so many tests that the participants went through, extensive genetics, really just a remarkable phenotyping and genotyping of a US based population. It's more than 50% female, and it represents African Americans, Hispanics, Caucasians, as well as Chinese Americans. So it really was a very impactful cohort and so rich in data. We just passed our 3,000th paper being published. So, as a study over 20 years. So, it's really remarkable in the amount of science that it's been able to generate. And it's open access. Anybody who wants to write a paper proposal can get involved in MESA and and get access to the data. It's a completely open access system. So it's really, I think, a remarkable opportunity for anybody to answer almost any epidemiological question related to primary prevention, at least from an observational standpoint.
Are there other similar registries and trials that you think will further inform on the role of coronary calcium as well?
Yeah, so coronary calcium was added to the Framingham Offspring study. Coronary calcium was added to the ERIC trial, another epidemiologic cohort in older Americans. But currently, we're doing a very interesting study called Rural. Rural is in the rural South. We just left Alabama and went into Mississippi. And it's a very interesting cohort study. It also has a calcium score in everybody, but the way we're doing it is having a mobile unit go into low income areas and areas that don't have good healthcare access and setting up a scanning operation there. And then we're taking the scanner to them. So it's a mobile CT scanner, and we're getting coronary calcium along with echo and EKG and other metrics to kind of emulate what we did in Mesa, but kind of taking it on the road in the rural South. So it's going to be a very interesting epidemiological study that also I think will be very rich in its opportunity to help inform us about maybe differences in that population, both due to social determinants of health, as well as maybe epidemiological differences in the rural South that we experience that we have not explored as much and don't understand as much.
That's great. Dr. Budoff, as somebody who has been seeing the journey since the beginning, in your opinion, how has the role of calcium scoring changed over the years in our multi-society guideline documents?
Yeah, it went from a test that we tried to introduce as a symptomatic test. All of the original studies we did were in symptomatic patients. We studied patients who were undergoing cardiac cath. We studied patients in the emergency department. Those were some of my earliest studies that I did back in the early 90s. And while the interest was always to use it as an asymptomatic cohort, there was really not great impetus there because there were no payers for it. The equipment was very expensive at the time. The original scanners we used were called electron beam CT. And those scanners cost $2 million back in 1995. So that was a huge cost burden. And therefore, the cost of coronary calcium scanning was high. We used to charge $395 a scan. So you talk about, social determinants of health and who can get a scan. if you didn't have a good amount of money laying around, there was no way you can get a calcium score if you were asymptomatic. So it really changed, though, over time as multi-detector CT became available. Calcium scoring became much more widespread, much more available, and much more cost effective. And now we're starting to see some payors cover the test. So it's really gone from a very niche advertised test. It was advertised on billboards and on the radio to now, I think, a fairly common risk stratification tool that's endorsed in our 2018 and 2019 guidelines by the American College of Cardiology, American Heart Association, and the European Society of Cardiology.
Thank you, Dr. Budoff. Could you elaborate on what the guidelines discuss about the role of coronary calcium?
Yeah, so the guidelines now are very, very favorable. I think starting around 2010, I was on a guideline committee with Dr. Greenland. Phil Greenland was the principal investigator. He chaired a guideline on asymptomatic detection of testing and basically endorsed coronary calcium in a fairly robust way. And since that time, more and more guidelines have followed that have incorporated coronary calcium. Now we fast forward to 2018, the cholesterol guidelines chaired by Scott Grundy. And now coronary calcium is built in as a recommended algorithm for those patients who have low intermediate risk, who are unclear whether or not they should take a statin. So it's become kind of a standard of care test, which is really remarkable over the past decade compared to what it was 10, 15, 20, 25 years ago, where it was impossible to convince anybody of the utility of the test.
That's right, Dr. Budoff. And to follow up on that, the discussion around statins and coronary calcium, continues both in academics and in clinical practice. So can you elaborate and help us understand on the utility of calcium scoring in patients already on statins? Do you see a role there?
Yeah, so let me just back up a tiny bit to the reason why there's a concern, and that is because statins tend to take some of the non-calcified plaque or soft plaque and convert it into calcified plaque. So the concern was that patients who are on statins are going to have an inordinate high calcium score because of the statin itself, and therefore the calcium score would be an inadequate or incorrect measure of risk. In reality, none of that is correct. It was really put forth by the intravascular ultrasound community that had very limited data on true coronary calcium, the way we measure it on CT, and rather on calcified plaque as measured by IVUS, which is a much different metric. Intravascular ultrasound is quite limited in its ability to see coronary calcium. And there's a blooming artifact with ultrasound that really limits its ability to measure calcium. So I think a lot of it's a misconception and an inaccurate representation of what happens. What happens in large, and remember, we have prospective randomized placebo-controlled trials of patients getting a statin or getting placebo and getting a calcium score at the beginning and a calcium score in follow-up. So we know exactly what the rates of progression are, and they are the same as the placebo groups. There is absolutely no propensity to increase calcification in any of these prospective randomized double-blind trials that says that statins cause a dramatic increase in coronary calcium. So Mike Blaha from Hopkins and myself and others have published a number of papers on this using the MESA cohort as well as the Calcium Consortium, another great study that Mike Blaha put together, pooling about 80,000 calcium scans from a group of different sites. It wasn't quite as prospective and it wasn't quite as comprehensive as MESA, but much larger in its number of scans. And both studies, MESA and the Calcium Consortium, both concluded that whether or not you're on a statin, the calcium score is equally predictive of future cardiovascular events. So calcium score of 100 is just as bad in somebody who's been taking a statin for 10 years as in somebody who's never been on a statin before. So I would just say ignore the statin literature. It's mostly a misconception put forth, unfortunately, by I think people who had secondary gains. And the science is based on double blind, placebo controlled randomized trials like the St. Francis trial and the Bell's study that show that calcium does not disproportionately accelerate coronary artery calcium as measured in CT scans.
Thank you, Dr. Budoff. To follow up on that, do you see any role clinically of serial calcium testing, especially in those patients who are on statins or Vazipa or other preventive medical therapy?
You know, I think with the advent of AI and the ability to do CT angiography, that's clearly better. A little pun there from clearly, but it's definitely a better way of looking at plaque burden and change over time is to do a serial CT angiogram. Now, that's challenging from a couple perspectives. One, cost, it's more expensive to do a CT angio, and two, participant burden. Contrast, need for an IV, potentially need for beta blockade, all the things that we have to deal with CT angio don't exist with a coronary calcium scan. But I do think that there is still some value in a serial calcium score. So if somebody has a low score, below 100, and let's say they're not yet instituting a statin, there would be a potential to change that if their calcium score went up over time. So what I institute is what's called a 1-3-5 year algorithm. If their calcium score is 0, and this is based on the guidelines, the cholesterol guidelines say if the calcium score is 0, you can repeat the calcium score in 5 years to reassess their cardiovascular risk. Did they develop plaque over the last 5 years? So that's 5. 3 would be if they had a low score and you wanted to see if they're now progressing to a higher risk category that may warrant either initiation of statin or increase in other therapies or even the statin dose itself. And one, if you have somebody who, for whatever reason, has a high score and is still not compliant with therapy, I sometimes repeat the calcium score 1 year later. And then if they are having significant progression of coronary calcium, it's an excellent motivator to get patients to initiate the therapy that you wanted. So I tell them, look, here's what we're going to do. 1 year, you had a scan a year ago, your calcium score was 180. We're going to do it again. If your calcium score is going up, I really want to start initiating some of these therapies we discussed. And it's remarkable how patients who were statin intolerant all of a sudden can take a statin now that they see their calcium score doubled over the last year, or that they're willing to take that PCSK9 inhibitor injection now that they see their calcium score going up. So it does change behavior, and therefore I do repeat it, not in everybody, but in some patients who I think might benefit from the increased adherence of seeing their score increasing.
Excellent. I think this discussion thus far has been very comprehensive from the perspective of clinical management. I want to shift now to clinical trials that we may be involving calcium scoring in for the future. There's certainly a lot of buzz around using calcium scoring for risk stratification of trial enrollees to ensure efficiency or cost effectiveness of trials. I'm curious to know what you think about this, Dr. Budoff, and what role calcium scoring may play in shaping or making more efficient our future clinical trials.
Yeah, and I think that this, again, is remarkable work by a remarkable group of young investigators led by Karam Nasir, as well as Ron Blankstein and Mike Blaha and others who've really moved the needle here quite dramatically. I think a lot of it goes back, if you look at the Jupiter trial, rosuvastatin versus placebo showed a 44% event reduction in primary prevention. However, the number needed to treat is very high, and the number of patients that they had to study in that trial was very large. That trial was 18,000 patients. So If you look at the patients who have Jupiter-like criteria, and we did this in MESA, only half of them have coronary calcium. And in that half, the number needed to treat is about 500. So you have to treat 500 patients for 5 years to prevent one event. If you were to only enroll those patients, the 25% who had calcium scores above 100, the number needed to treat is 24. So you could have reduced the size of Jupiter 20-fold and had the same benefit, same statistical benefit, and same robust outcomes with 20-fold less patients. So I think that many trials now are starting to learn about this, and there are trials going on now with both inclisiran and with PCSK9 inhibitors that are using calcium scores as an entry criteria for clinical trials. And patients who have a calcium score above 100 are being entered into the trial preferentially. They're not excluding patients with lower calcium scores, but I think that as we learn more, we're going to understand that this is really a way of optimizing care and not having to do a $1 billion trial. These trials cost $1 billion to do these big outcome studies, that we can scale that down maybe 20-fold and do these trials for 50 million, 100 million, which is still a lot of money, but a lot more trials can be done if you can do 10 trials for $1 billion instead of one, as we think about where we're going to spend our dollars and where pharma might want to spend their dollars to validate their technology.
That's great, Dr. Budoff. Thank you. And now we want to move on to discuss the buzz around the most recent trial that was presented at ESC 2022, the 5-year outcomes of the Danish cardiovascular screening trial, DAN-CAVAS. Based on their data, the invitation to undergo comprehensive cardiovascular screening did not significantly reduce the incidence of death from any cause among men 65 to 75 years of age. What are your thoughts on the trial?
Yeah, so two things. One, it was powered to be a 10-year study. So this truly is an interim analysis. If you read Dan Cavas's study design, it's supposed to be a 10-year study, and that's how they powered it for events. So it didn't hit statistical significance at 5 years, but I think that there is one remarkable number that came out of that trial, and that is that for the patients who actually participated in the screening. So remember, it was an invitation to screen. 36% of patients did not acknowledge their invitation and did not show up, yet they were included in the screening group for the purposes of the analysis. So that's a very unusual way to analyze data, because if I invite patients to participate in the Jupiter trial and they say no, I don't consider them on rosuvastatin. And then if they have an event, say rosuvastatin failed, I'd say they're not a participant in the trial and they're not consented. So if you excluded the patients who didn't show up and you said, okay, what about the 64% of patients who actually got screened? How did they do compared to the control group? The event reduction was 50%. So you could say it was the most remarkably positive trial in the history of prevention, that if you did get a calcium score, you had a 50% event reduction as compared to those participants who were in the no CAC group. Or you can say that it had a p-value of 0.08 and only had a non-significant 7% reduction in events. The younger cohort had 65 to 69, which is more in our screening population. Remember, they screened 65 to 74-year-olds, and you can argue people in their 70s don't need coronary calcium scans. They need to be treated. The people in the 65 to 69-year-old pre-specified cohort actually had a 11% significant benefit in mortality, all-cause mortality. So you have obviously a little disappointing that it didn't hit overt statistical significance, but the younger cohort was highly statistically significant, and the group that actually got screened as per protocol, the on protocol patients had a 50% event reduction. So I'm very enthusiastic about the 10-year follow up, but also I'm more enthusiastic about the Rubinska study, which enrolled people to, and once they decided to participate, then randomized them to screening or no screening. So everybody is participating in the trial and not just a random invitation that might have gone unnoticed or gone to the wrong household or had been never delivered by the mail.
Excellent. Dr. Budoff, critics out there say, coronary CTA can be performed with low radiation and provides AI-based plaque characterization. With that in mind, do you think we still need calcium scoring?
Well, if you think about the cost implications of a calcium score, which Medicare currently reimburses at about $95, I believe, somewhere below $100, or the implications of a CTA with AI, which I believe the current cash price now is about $1,200. I think would strongly favor coronary calcium, unless you believe that CTA is 12 times better than a coronary calcium score. And I don't believe that's ever going to show that the hazard ratio from a plaque assessment on a CTA is 12 times greater than that of risk stratification by a calcium score. I think when we talk about the implications across a wide berth of patients, we're going to have to use a calcium score, utilize the power of zero to eliminate a large population of patients who do not need further testing. Shown in so many trials now and advocated by our guidelines, right? The guidelines say if you have a calcium score of zero, you can withhold statin therapy for 5 to 10 years. That's a remarkable statement based on excellent epidemiological and observational data from very large cohorts. And I think will bear out. So I'm very confident that when I see a patient with a score of zero, I don't need a CTA and I don't need to spend the money on AI. And I've eliminated at least half of the population that I could now, if I wanted to focus on who needs an AI assessment with CTA, I would use my calcium score to reduce that by 50%, and then take anybody with a positive CAC or maybe a calcium score above 10, and then subject them to a CTA if you really wanted to derive all that extra benefit.
So just a follow-up question on that, Dr. Budoff. There have been some observational studies that show that between 5 to 10% prevalence of non-calcified plaque in those people with CAC 0. Any thoughts on that?
Yeah, so there's remarkably great data that's come out of Danish registries that have shown that if you have a calcium score of zero and documented soft plaque, you have the exact same outcomes as if you have a calcium score of zero and no plaque on CTA. So isolated non-calcified plaque has never been shown to be prognostically important in any cohort, including the CONFIRM trial in asymptomatic participants. If you look at asymptomatic patients in CONFIRM, and there's been 2 papers on this, there's no incremental value of doing a CTA on top of a calcium score. Now, in symptomatic patients, that's different. In symptomatic patients, especially in the emergency department, you can have, a rupture of a plaque that could be non-calcified. You can have thrombus. You can have embolism. I'm not talking about an acute chest pain participant. I'm talking about a screening population. I don't believe there's any value ever shown for CT angio on top of a calcium score of zero in any outcome study. So while there is a small prevalence of a small amount of non-calcified plaque, and a rare person will have an obstruction of 50% or more, those have not been shown to be important for prediction of myocardial infarction, stroke, or cardiovascular death, the endpoints that we care about in preventive cardiology.
Thank you. And now switching gears to acute chest pain management and evaluation, what do you think about the role of coronary calcium or the power of zero in acute chest pain?
Yeah, so I was very surprised, actually. I wasn't involved in the most recent chest pain guidelines, the 2021 guidelines, that actually reintroduced coronary calcium for low risk patients with chest pain. And I've always been an advocate of that, going back to a study that I published back in the early 90s that showed that if you had a calcium score of 0, you had 0 events, not over the first 30 days that we care about after an emergency department visit, but after the next 8 years. So we had excellent prognosis and I studied patients who came into the emergency room with acute chest pain, low probability of obstructive disease based on a normal EKG and normal troponin, and they had or probably a CKMB back then, and they had no events if their calcium score was 0 for the next 8 years. It was published, the first author was Giorgio. It was a study that I scanned most of the participants and wheeled them from the emergency department into the scanner to get a calcium score when they came in. But I think that has been borne out by large data sets. So low risk participants, low risk chest pain patients who have a score of 0 can be safely discharged. That's in our guidelines now, chest pain guidelines. And there's a large number of papers, a lot of them done by John Mamarian and Dr. He in Houston, some done by Dan Berman at Cedars, and some done by my group in Los Angeles, all showing that a calcium score of 0 in a chest pain patient, an acute chest pain patient, is still a good prognostic sign and lends itself to a very low risk of future MI, stroke, or cardiovascular death.
So, Dr. Budoff, with all of these data in mind for not only asymptomatic populations, but also symptomatic populations, one would imagine that the uptake of coronary calcium scoring would be relatively high. Wonder now if we could speak to some of the roadblocks or resistance to taking on coronary calcium in clinical practice.
Yeah, so I think there's been 3. So one and the most important is reimbursement. So when you are not reimbursed and the insurance company says that the test is considered experimental, right? So one of the insurance companies still does that, then it sends a message to the patient that maybe they shouldn't have gotten the test. And I don't know when a test goes from being non-experimental or goes from being experimental to some other terminology. But I can tell you that after 30 years and tens of thousands of papers, I think it should no longer be called experimental. If they don't want to pay for it, then they should say that it's just a non-reimbursed test. And it's in our guidelines now for both acute chest pain, only for low risk. I'm not advocating it for the average person who has chest pain in the emergency department. I think a CT angio is far, far superior for symptomatic patients. But it's advocated for asymptomatic patients. It's advocated for symptomatic patients in our guidelines. And I think it's time that we recognize that we have to kind of keep pushing back against the insurance companies that are using data from the early 90s to say that they don't want to pay for it. The second reason, after not being reimbursed by the insurance company, where we get pushback, is this fear of radiation. And as you know, a well-done coronary calcium score should be about the same as a mammogram. When I met my boss, Bruce Brundage, back in 1990 as an intern, and I talked to him, he told me, I want you to start helping me research this test. It's going to be the mammogram of the heart. He says it's going to help us identify who has disease, early disease, and who does not, and we can treat those people with early disease just like we do for mammography with breast cancer. And he was exactly right. And I thought, wow, this is obvious and it's going to take off. And it took 30 years to get it from that concept into the guidelines. Unfortunately, Dr. Brundage and I are both around to see that happen, but it's a remarkably long journey that it's taken. But this concept of radiation is a problem because patients have been told it's a high radiation test. I don't know where that comes from, but the doses should be at least about the same as a screening mammogram, about 0.6 to 0.7 millisieverts, and really should not be a barrier to getting a test when background radiation is 2.5 to 3 millisieverts per year just for being alive and being on the planet. The third barrier, if we consider the first to be cost and the second to be to be radiation would be the pushback by certain physicians that still are against it for all the reasons that we've talked about today. It's going to miss soft plaque. It's going to raise anxiety. It's going to cause downstream testing to go up. None of these things have borne out in large studies. We looked at downstream testing after CAC in the MESA trial, and there was no increase in downstream testing after 6,814 participants got a coronary calcium score. We saw no increase in utilization of other tests of any significant number. So I don't think that in the right hands, given the right way and given with good explanation, that it should either cause anxiety or increase testing, but it does have that potential, and we need to make sure that we deliver this test in the most appropriate manner in an educated way. But I've seen huge uptake across many physician groups, and it's just been heartening to see this test being used so widely now and being supplemented by coronary CT angiography as another way of getting at some of the same answers in higher risk patients or in younger patients where coronary calcium score may be negative and a false negative at that.
Thank you, Dr. Budoff. I have worked with you and known you as a visionary in this field for coronary calcium and cardiac CT. So I'm kind of excited to hear your thoughts on what do you envision as the next best thing that's going to come both for coronary calcium and for cardiac CT in cardiology.
Yeah, so I think that a coronary calcium scan, I think this is really the tip of the iceberg of the information that we get is the actual calcium score. And the calcium score, even if you ask Arthur Agatston, who helped design the score, is suboptimal. And we all know that. And we need to modify the way that we quantify the calcified plaque. Density is probably somewhat protective, and we upscale the calcium score based on a higher density. And that might represent the more stable plaque. But I think if you think about what you can see on a calcium score, we get chamber sizes. We can see the left ventricular size. We can see the left atrial size. We can see the pulmonary artery and the aorta. We see epicardial fat, which is a metric of visceral fat. We can see aortic valve calcium and mitral annular calcium, which may have very important prognostic implications. Descending thoracic calcium may be of interest. I'm now studying aortic arch calcification on lung CTs because we can't see those on a well-done calcium score because we don't go around the arch. We don't cover that territory on purpose to keep the dose low. But on a lung scan, we see the arch, and we're seeing if that has prognostic significance. So I think that when you start pooling all of these different measures, liver fat, bone density, all of these things are available on that scan. You're going to get so much information for your patient in one simple scan at less than 1 millisievert that it's just going to answer a lot of clinical questions about cardiometabolic disease and bone fragility and other risks that patients are suffering, including risks for heart failure and AFib. If we look at the chambers, I just think that we're just getting the tip of the iceberg as far as what we can do with the scan. And computers are going to automate this where it's not going to take 18 hours to make all these measurements like it takes today, but we're going to do it in 18 seconds when we run it through a computer algorithm and come up with 7 answers for the patient, not just what's your calcium score.
That's great. Dr. Budoff, you have been an amazing mentor to many of us. If you could give any recommendation to our trainees and early career imagers, that would greatly benefit them.
Yeah, so I would say that, if you have a passion for this field, is to pick a portion of it. And that's true of anything in medicine. Pick a portion and become somewhat of an expert in that area. For example, with CT, there's obviously structural. There are people who just do atrial imaging, transmitral imaging, or TAVR. You can do, it can focus more on coronary calcium. There's been some very notable experts that have become very prominent in the field by focusing on coronary calcium scanning. You can focus on asymptomatic use of CT and CT angio and asymptomatics, but pick a portion of the field. EP imaging, there's just so many parts of CT angiography, and try to focus on that and write papers on it and become an expert through literature. Because when we look for experts to be on panels, and when we look for experts to be on writing groups, we look at the literature to see who's written on that. And if your name comes up, and there's good examples of that, Karam Nassir has become very prominent with the power of zero because he's written a lot about it. Mike Blaha has become very prominent. Jonathan Leipzig is the TAVR guy because he focused on TAVR and the use of CT in that field. And the list goes on, right? So if you look at each president of the SCCT, each of them had a subspecialty, if you will, in CT that they really developed their niche in and they were known for. They're not just, they're just another CT imager. So I would definitely focus on one facet of it and try to write review articles, maybe write some original research, work with people if you really want to, become an academic in this field. But CT is growing rapidly. I get so many requests. I have 4 fellows a year now in my CT fellowship, and there are just so many opportunities for them that groups are looking for people who can do CT, who can add CT to their practice. So I think it's just a remarkable time to be in this field and a great opportunity to really move the needle forward.
Dr. Budoff, this has been an extremely insightful conversation. Truly, thank you so much for giving us your time and expertise, not just us on the podcast, but the entire community. Wanted to ask if you have any last thoughts before we close.
Well, no, I just think we're in a very fortunate time where there's a lot of opportunity to collaborate. There's just so many unanswered questions. Every time we think we've answered a new question, it opens up another 5 questions that could be looked at. And again, with the advent of AI and all of these other metrics that we can see on the CT, I think that there's just a great opportunity for everybody to get involved and really help us move the scientific needle forward and answer those questions that are being asked of us, and sometimes quelling the skeptics with science, because that's the best way to show the science is that what the right answer is by doing the study rather than by making suppositions, which has been the case, unfortunately, in this field for a long time, is that opponents have basically thrown out, random things or observations based on one patient and tried to make that the stake in the ground. And that's, we can prove them wrong or maybe prove them right. Maybe they are correct. And we just need to do the science. So join the movement, get the science out there and help us answer the questions that'll move both clinical medicine forward and also hopefully advance CT both in the guidelines and in clinical practice.
Awesome. Thank you so much again, Dr. Budoff, for your time and expertise. Really, really appreciate it. To my co-hosts, thank you both as well. I think this conversation was fantastic. It's going to be super, super interesting for all of our audience members that are familiar with cardiac CT and even those unfamiliar that are yet to join. To our listeners out there, thank you very much for tuning in. If you like what you hear from us on the podcast, please rate, review, and subscribe to us. Once again, this is the Donut of Destiny. Cheers.